Good evening, everybody. Today we are going to see about fetal arrhythmias. Fetal arrhythmias are not that common in our practice, but this is the only condition which can give gratifying results if it gets picked up early, on time, and gets managed properly. Fetal arrhythmias actually happen in 1 to 2% of all pregnancies. However, a majority of these arrhythmias are basically benign in terms of extrasystole, and 6 to 15% of these arrhythmias are associated with structural heart disease, and hence a detailed fetal echo or structural analysis is also indicated whenever an arrhythmia is suspected. Presence of arrhythmias, why should we worry? Is there anything to worry if we see arrhythmias? Anybody? We can have answers from all of you. If we have arrhythmias during fetal life, why should we worry? Yeah, fetal demise and hydrops. Hydrops is the major threat which can happen in presence of arrhythmias. And initially, it can just start with cardiomegaly, some amount of AV-valve regurgitation, and finally land up with hydrops. And it increases the mortality during pregnancy and even after delivery. And it can also produce morbidity in terms of neurological damage. So now, what are we going to see in today's class? First of all, when do we suspect abnormal rhythm? Second thing is, when we suspect, how do we diagnose and differentiate them? And then we will look into the individual details of extrasystole, bradyarrhythmia, and tachyarrhythmia and their management. So when do we suspect an abnormal rhythm? To understand that, it's important for us to know what is a normal heart rate. A normal heart rate ranges from 140 plus or minus 20 early in gestation and can go up to 130 plus or minus 20 at term. So on an average, a rate of between 110 to 150 to 160 is considered to be within normal range. Though with this understanding, we can have some amount of physiological variations also. Heart rates can go as low as 70 for 3 to 4 seconds, or it can go as much as 180 transiently for 3 to 4 seconds. Transient bradycardia is commonly seen, especially while applying pressure on the abdomen while doing a scan. And occasional ectopic beats can happen in 10% of normal pregnancy. So these things are not considered to be abnormal. Then what is abnormal? Abnormal rhythm is defined as a heart rate more than 180 per minute which persists for more than 10 seconds, or if it's less than 100 per minute if it's more than 10 seconds. And if ectopic beats are happening more than 1 in 10 beats, then it is abnormal. So tachycardia is more than 180, bradycardia is less than 100, and frequent irregular beats are more than 1 in 10 beats. Now, once we suspect abnormal rhythm, a little thing can be done for the history in terms of asking the mother about fetal movements and any family history of long QT syndrome, WPW syndrome, or tuberous sclerosis. So there is very little history basis we can get information, and it's rare to get something on history. Examination, the cornerstone of diagnosis is M-mode and Doppler echo to pick up the atrial rate, the ventricular rate, and the atrioventricular relationship. Though we have certain techniques like fetal magnetocardiography and electrocardiography available in selected centers, which can detect P and T waves and exactly define the PR interval and the type of arrhythmia, in our practice what is available is M-mode and Doppler echo. So when we start doing the fetal echo, we have to pay attention to the 2D understanding of the image in terms of qualitative assessment. We can have an understanding of cardiac signs and the series of heart function. Sometimes arrhythmias like atrial flutter can be just perceived by naked eye, seeing the movement of the atria. The next important thing is the M-mode, where we can cut the atria and the ventricle, either the right or the left, the wall of the atria and the ventricle, to get the movement of the atria and the ventricle. The problem in this is we cannot clearly define the VA interval or the PR interval and in presence of poor ventricular function, it gets difficult to perceive the ventricular motion. The last thing is the Doppler, where we can Doppler independently the atrial activity by Dopplering the SVC, IVC, hepatic veins, or PFO, or even AV valves, and the ventricular activity can be picked up by Dopplering the LV outflow or the RV outflow. When we want simultaneous understanding of atrial and ventricular activity, we can either use the LV inflow outflow view, or we can use the aorta and the SVC together. Now we will see these things in detail in the subsequent slides. I think I'll go back again because it was playing some time ago. Just give me 2 minutes. I think I can go at the end of it and share it from the